On behalf of Niramaya Arthritis and Immunology Foundation, Jaipur, I welcome you all for this virtual rheumatology meet, Rheumatology Clinical Pulse, and today's topic is rheumatoid arthritis. We all know that RA is the most common rheumatic disease, and I believe 2/3 of OPD bulk is of rheumatoid arthritis. Interestingly, in spite of this, we face new challenges every day in managing RA patients. Window of opportunity and diagnosis of early RA is the current theme world over, but still it's challenging to make correct diagnosis when things are subtle or subjective only. Similarly, in advanced disease, it's challenging to find out the exact cause of patient symptom because etiology may be because of rheumatoid disease activity or because of mechanical problems due to deformities or medication related or associated comorbidity or psychosomatic components. So it is very, very important to diagnose the exact cause of the symptom in advanced disease. And lastly, few rheumatoid arthritis complications we see mostly in late disease. It is important to be aware of these. With this background, we will discuss two interesting topics. One is seropositive polyarthralgias. When is it early rheumatoid arthritis? This will be discussed by Professor Ashok Kumar sir. And second topic is what all should be looked while managing advanced RA. This will be discussed by Dr. C. Balakrishnan. And after that, we will discuss all the questions related to these two topics. I request all the audience to send their questions in chat box so we can discuss relevant questions. Regarding speakers, Professor Ashok Kumar sir and Dr. Balki, two of the finest clinicians of our country, and we are lucky to have them for this important topic. Professor Ashok Kumar sir, he is MD, FRCP, Clinical Director and Head Department of Rheumatology, Fortis Hospital, New Delhi. He was Professor and Head at AIIMS Rheumatology Services, New Delhi from 1994 to 2009. So he served, he was professor in AIIMS for 15 years and he trained more than 50-60 rheumatology students. He was a recipient of Noel Oration of IRA 2001, President IRA 2007 to 2009, Editor Indian Journal of Rheumatology from 2006 to 2009, recipient of Dr. M.N. Pasi Award of IRA, that is the highest IRA award for Lifetime Achievement 2016, and Ahuja Bajaj Outstanding Clinician Award in 2021. He published more than 200 research papers. His areas of special interest are spondyloarthropathy, rheumatoid arthritis, and systemic vasculitis. Second speaker for today's meet is Professor C. Balakrishnan. He is consultant rheumatologist at PD Hinduja Hospital, Mumbai. He did his MBBS from Madras University and he was the best outgoing MBBS student. He did his MD from Pune University and he secured highest marks in MD. He did his rheumatology training under Dr. V.R. Joshi sir at PD Hinduja Hospital, Mumbai. Then he went to UK and trained at Royal National Hospital for Rheumatic Diseases, Bath and Southend General Hospital, UK. He has more than 30 years rheumatology experience. He has published more than 80 research papers and he's running DNB rheumatology course at Hinduja Hospital. His special interests are lupus nephritis, soft tissue rheumatism, and infections in rheumatic disease patients. Now I request Professor Ashok Kumar sir to start his talk. And again, I request all the audience to send their queries in the chat box. Thank you.
Thank you, Banwari, for the kind words of introduction. I will just try to share my screen first. What's happening? Okay. Is it visible now?
Yes, sir, it is visible.
Oh, great. Somehow my lower part of screen is getting cut due to the, wait a second. All right, that's better now. Right, the topic for my talk is really very interesting, and this is Dr. Banwari Sharma's choice. Rheumatoid arthritis, as you know, reduces both the quality of life and survival of the patient. Early treatment is the cornerstone stone of management, and this implies that we must obtain an early diagnosis. Rheumatoid factor and antibodies to citrullinated protein antigens, ACPA, are very helpful diagnostic markers, and they are easily available. But improper interpretation of these markers has created new challenges in current practice. Now, as you know, 70 to 80% of RA patients have rheumatoid factor and or ACPA. When a person is diagnosed with RA, often his family members or siblings also get themselves tested. And when they turn out to be positive, they get very anxious. Some patients get these tests done for any musculoskeletal complaint and are shocked to see positive results. Are these people suffering from early RA? That's a very crucial question, because a lot of people start giving treatment to such people, hoping that they will be able to nip the evil in the bud. But we'll try to obtain the answer to this question in the next few slides. Now, we need to actually go into the pathogenesis of rheumatoid arthritis to understand the answer. Now, RA is a triphasic disease according to the current understanding. The first thing is genetic predisposition. Second, after interaction with environmental factors, development of asymptomatic autoimmunity. And the third phase is the final phase, where rheumatoid arthritis appears in its early stage. Now, my aim is not to discuss genetic predisposition in this talk, but suffices it to state that the contribution of genetics to the pathogenesis of rheumatoid arthritis is to the tune of 60%. HLA and non-HLA, both category of genes are involved. And the risk to first-degree relatives of rheumatoid arthritis patients is certainly increased to about 3 to 5 times. The genetic risk is much more in multi-case families. Multi-case means that a family which has 2 or more cases of rheumatoid arthritis. Alan Silman from the UK actually had a whole lot of these first-degree relatives, numbers, 370 such families, where he conducted annual examination for 5 years and found that the annual incidence of rheumatoid arthritis in such families increases from 0.05% to 0.8%, which is a 16-fold increased risk. Mind you, I'm talking of incidence, not prevalence. Prevalence of rheumatoid is 0.5 to 1% in the community, but incidence is much, much lower. So if baseline rheumatoid factor positivity is also there in such a person, then the risk increases even further to 74-fold. So which means incidence of 3.8%. However, absolute numbers you can see are still small. Now, Neelen et al. From the Netherlands tried to estimate the 5-year risk of rheumatoid arthritis in asymptomatic subjects. So ACPA positive asymptomatic individuals, if you find in the community, their risk of developing rheumatoid arthritis in 5 years is 5.9%. If the person is ACPA positive and is first-degree relative of multi-case family, then the 5-year risk is 69%. And suppose both ACPA and RF are present in the first-degree relative of a multi-case family, then the risk is 100% in 5 years. So that's the importance of genetics. Environmental factors are mentioned here. They are very well known to all of you, and I will not spend much time on this, but they have a role. Now, the European League of Rheumatology has actually further split the pathogenesis into 6 phases. Phase A is of presence of genetic predisposition. Phase B is the environmental factors which act upon this genetic predisposition. Phase C is the development of rheumatoid factor, anti-CCP, and other autoantibodies. Phase D means development of some symptoms, but they are not amounting to any synovitis or arthritis. Phase E is that of first appearance of some arthritis, which we can call undifferentiated, but not exactly RA. And phase F is the development of rheumatoid arthritis, which is classifiable. In other words, you can say that the Euler model states that there is an asymptomatic phase and there is a symptomatic phase. The asymptomatic phase, I have already stressed, genetic factors, environmental factors, and development of seropositivity. Then the symptomatic phase is something that starts with non-specific arthralgia or body pain, goes on to undifferentiated arthritis, and then finally development of rheumatoid arthritis as we recognize in the clinic. Now the two questions arise. Number one, how much time will it take from the seropositivity stage to development of rheumatoid arthritis, or at least some undifferentiated arthritis that can be recognized? The second question is, how much time will it take from the stage of non-specific body pain or polyarthralgia to development of arthritis? Now, the first question was addressed by Nielen et al. From the Netherlands. What is the interval between seropositivity and development of clinical phase? Now, Nielen et al. Conducted a very interesting study. They recruited patients with rheumatoid arthritis who had been donating blood in the past on a regular basis. So somebody may have been donating for the last 15 years. So their samples were stored by the blood bank. So frozen serum samples from each donor were retrieved together with two controls matched for age, sex, and the date of donation. And all these samples were tested for IgM, rheumatoid factor, and ACP. Interestingly, 39 out of 79 such people who had rheumatoid arthritis and had donated earlier were found to be positive for the serum markers. So seropositivity preceded symptoms of RA in this particular study by a median of 4.5 years, but the range you can see is 0.1 to 13.8 years. That means somebody had been having these markers present in the blood for as long as 14 years before the first appearance of rheumatoid arthritis. That was a very important insight. And this is the graph, which shows years before development of rheumatoid arthritis. So you can see 14 years also had a few entries here. The second issue was addressed by Paul Emery's group from Leeds University of UK. That is predicting the development of clinical arthritis in anti-CCP positive individuals who have only non-specific musculoskeletal complaints. So they had patients with new onset non-specific musculoskeletal complaints who had ACPA positive in their blood. They were recruited from regional primary care and secondary care referrals. Exclusion criteria were presence of arthritis, and anyone who has taken DMARD was also excluded. The assessment protocol was at baseline 3 months, 6 months, 9 months, and 12 months, and then as clinically indicated. The endpoint was development of arthritis as observed by a clinician in at least one joint. And the parameters they took note of were age, sex, BMI, history of smoking, alcohol intake, family history of RA, duration of early morning stiffness, 44 swollen joint count, tender joint count as per Ritchie's index, and ultrasound with power Doppler examination of the wrists, MCP joints, and PIPs also. And this is the baseline demographic data. There were 100 patients, mean age 51 years, 72% were females, BMI was 25 or more in 71%. Nobody had synovitis as per the inclusion criteria. CRP was 20 or more per liter in 58%. All were ACPA positive. 46% had rheumatoid factor as well. And ultrasound detected power Doppler signal in 33%. So that was the profile. And what were the results? After a follow-up of 19.8 months, which with a range of 0.1 to 69 months. 50 developed arthritis after a median of 7.9 months. The range was 0.1 to 52.4. The other 50 remained free of arthritis. The breakup of 50 patients with arthritis is that by 8 months, 25 had developed arthritis. 12 months, this number rose to 34. And the 50th patient developed arthritis after 4.3 years. And also remember that most of them fulfilled the ACR Euler criteria for RA, but there were 7 who were still undifferentiated. And as many as 50 had not developed any RA. They also created a risk model based on these 5 points: hand and foot tenderness, early morning stiffness more than 30 minutes, high positive rheumatoid factor, high positive ACPA, and positive ultrasound power Doppler signal. So depending on the number of points present, so the high risk category was 3 or more points, where there were 66 patients, and the risk of developing arthritis was 62%. Now, should we treat seropositive polyarthralgia? In this particular study, you might argue that the high risk category can be started on disease modifying therapy. Now, this group had 62% chance of developing arthritis after a median of 8 months. If you started all of them, then 38% patients will get treatment which is not justified, which means you are indulging in over treatment. And then you also know that many of these patients may not develop for a very, very long time. They may just remain non-specific musculoskeletal kind of syndrome. Now, let us look at some more data. These kind of thoughts come to researchers that, we could take some extreme measures, give massive dose of steroid in patients who are just detected to be seropositive and, they are at a very early stage of symptoms. So Bose et al., they had 83 patients with seropositive arthralgia. They gave intramuscular injection of 100 milligram dexamethasone or placebo at baseline and after 6 weeks. So 2 injections of dexamethasone. The primary endpoint was 50% reduction or normalization of antibody titer at 6 months, and secondary endpoint was prevention of arthritis at 2 years. The results were, there was indeed a fall in antibody titer in the treatment group, but similar proportion of patients developed arthritis in the 2 groups. So there was no prevention that happened. This is another study which used rituximab. Now, this has been called Prairie study. This is from the Netherlands, a multi-center double-blind placebo-controlled trial. 82 subjects with seropositive arthralgia, CRP more than 3, and or synovitis on imaging, MRI or ultrasound, but clinically no arthritis. They were randomized to 1000 milligrams of rituximab infusion or placebo. So there were 2 random groups and were followed up for development of clinically manifest arthritis. Now, 1 patient dropped out, 81 participated, 64% were females. The mean age was 53 years. They received treatment. After median follow-up of 29 months, 30 developed arthritis. In the placebo group, 16 out of 40, that is 40%. In the rituximab group, a little less number, 14 out of 41. So this would not be any significant difference. But if you counted at 12 months, then the hazard ratio of developing arthritis in the rituximab group was less, that is 0.45. That means 55% reduced risk. In the rituximab group, 25% of patients developed arthritis at 24 months of follow-up, while the same happened at 12 months in control group. So the conclusion was that the rituximab was able to delay the onset of arthritis by 1 year in patients with seropositive arthralgia, plus imaging evidence of synovitis. But it did not actually prevent, it only delayed the onset. There are other trials on seropositive arthralgia which are still awaited. Now, these two are actually on a beta set. Results are expected this year. Then there was a systematic literature review and meta-analysis. The ability of disease-modifying anti-rheumatic drugs to prevent or delay rheumatoid arthritis onset. Now, in this, I will only tell you the summary results. From 2006 to 2016, 595 abstracts were screened and only 10 were selected. So you can understand the studies had so many shortcomings because the groups were not comparable, or they had some other major drawbacks. So mean duration of undifferentiated arthritis or seropositive arthralgia was 16 weeks. So these were very early cases. Methylprednisolone, methotrexate, TNF inhibitor, abatacept, or rituximab, any of these were used. But I just want your attention to be drawn to the fact that the two trials on seropositive arthralgia did not reduce the occurrence of RA at week 52. Trials on undifferentiated arthritis, they showed reduction in occurrence of RA, odds ratio 0.73. Now, undifferentiated arthritis anyway is a very different ballgame, because naturally also they may evolve in different directions. They may not be cases of rheumatoid arthritis as such. So this is a recent viewpoint article written by experts in this field, and they have given a very interesting title to their article: the earlier the better or the worse, towards accurate management of patients with arthralgia at risk for RA. Basically, they have tried to mention, express the sentiment that as of today, we don't have solid data because studies have not been done properly, and we still need to reach a conclusion as to what exactly represents imminent RA. And our prediction models are still very, very poor. Now, EULAR expert group had actually attempted to come up with this term, arthralia at risk for RA. This has also been called clinically suspect arthralgia. So they really, in a formal way, a group of 18 rheumatologists tried to work out what represents arthralgia at risk of RA. So they were able to list 7 features, 5 on history taking and 2 on physical examination. Joint symptoms of recent onset, duration less than 1 year. Symptoms located in MCP joints. Duration of morning stiffness 60 minutes or more. Most severe symptoms present in the early morning. Presence of a first degree relative with RA. Difficulty on examination with making a fist, and tenderness on squeeze of MCP joints. Now, presence of 3 or more of these features will qualify for the definition of clinically suspect arthralgia. And EULAR expects all future studies to make use of this as inclusion criterion, so that there is a uniformity in the conduct of clinical studies. So I would like to conclude here that seropositive polyarthralgia often comes with non-specific complaints and is frequent in clinical practice. It is a stage in the pathogenesis of RA. Treatment of preclinical RA is still a work in progress. Studies are going on and results are keenly awaited. The urge to start DMARDs should be resisted until clear features of inflammatory arthritis emerge. For undifferentiated arthritis, at present, there is a consensus that they should be treated with disease-modifying drugs, but not before that. And we must await the results of the studies that are ongoing at this stage. Thank you very much. I will close my talk here. And
thank you, sir. Excellent talk. And we will take questions after the Balkis talk. So I request Dr. C. Balakrishnan to start his talk.
I just wanted to check my slides are being shared there.
Yeah, it is.
Thank you. Thank you. So I thank Dr. Banwari Sharma for inviting me to be one of the panelists and a speaker at this very clinical meet. And the topic given to me is what all should be looked at while managing advanced rheumatoid arthritis. So I think I'll go through one by one the things that came to my mind when he gave me this topic. I think the most important would be patient education, because the patient knows everything by the time he's come to you. He knows what rheumatoid is. And with the presence of Google and many other things, his knowledge is there. So when he comes to you, the first thing we need to do is he knows about all the new medications too. So the expectations need to be tempered. So he thinks that everything can still be cured with all the new medications. So maybe we need to take some time to temper his expectations. The second part is he needs to know that even now medications need to be taken to control his disease, even though it's long-standing. The second thing is we need to tell him about the comorbidities, because these patients have had arthritis for a few decades and are usually in their 4th, 5th, or 6th decades of life. And when comorbidities are common, they've had a lot of pill burden, so their body has taken a lot of these drugs. So we have to be careful with the comorbidities. Even now, we need to emphasize on the need for exercises. And my usual thing is when these long-standing rheumatoids come, I do give them a view as to what would happen to their joints in future, what I'm thinking about, which joints are the ones which may need some surgical intervention later on. So if you say all this from the very beginning, then they don't come up with a shock when you tell them about this later on. So it's a very good thing to do if you can assess this and then tell them, saying that, look, at the moment we are treating you, but these things might be needed in future. Now, the most important thing to realize is even though the disease is very long-standing, we used to use a term called burnt out RA, which is no longer used because a significant proportion of them have activity, or a significant proportion of their disability is because of disease activity, which should never be missed, because that's something that can easily be reversed even at this stage and give them a better quality of life. Sometimes joint damage makes it very difficult to assess disease activity. And we might have to depend on symptoms that the patient tells us, the inflammatory markers that is there, and then give them the benefit of doubt and treat them for whatever disease activity they have, and then review the situation. Treatment can be challenging, as many DMARDs have already been tried before they've come to you. So you have to sift through the data of DMARDs that they have used, which has been used appropriately at the right dose for the right period of time or not, and then select a proper DMARD. Comorbidities can make the selection of DMARDs a little difficult, but the newer drugs that have come in have made therapeutic choices a little easier, and therefore we have avenues to and doors to open, even though they've had a long-standing disease. So I'll go to the articular problems due to joint damage, and I will be discussing these 3-4 things. Pain relief, which is very important, which is what they're looking at. Planning the orthopedic surgery, which is important. Preoperative evaluation of these patients. And a few joint areas which are not usually discussed, but often the problems in patients with long-standing rheumatoid, including temporomandibular joint and cervical spine, which do come up. Although the prevalence has gone down, we do see them, and we need to know and pick them up and treat them. As far as pain relief in long-standing rheumatoid is concerned, we need to be careful with NSAIDs as ever. And because these are elderly with a lot of comorbidities, you need to be very, very specific in selecting patients for NSAIDs. Analgesics, on the other hand, are more easily used. So paracetamol, myospas, plain myospas, tramadol, etc. are used more often. Activity of the disease, and maybe oral, if you're giving it as an oral, to give it for a short period of time may not be a bad idea. Central pain inhibitors and blockers are also of importance, including amitriptyline and nortriptyline can be used along with analgesics. Local injections are important in joints which are painful and the patient is not contemplating surgery very soon. Nerve blocks, which if you can learn nerve blocks for painful areas, especially in patients who are not contemplating surgery, are very useful. I would give the example of suprascapular nerve block, which is often used for severe shoulder joint pains and before other surgical ventures are thought about. Orthotics and footwear are important, and the role of physiotherapy cannot be belittled. So all these things are important to reduce the pain in these patients. Pre-operative assessment is important for those who go. So cervical spine, lung, and something that is missed is eyes. We've had patients with Sjogren's, secondary Sjogren's, and often I tell my anesthetist to keep putting drops, especially in prolonged surgery when they're in the OT, because sometimes when they come out with lacerations of the cornea, which could have been easily averted, with just as a word to the anesthetist. I think this is an important thing that sometimes is missed. Steroid stress cover for those on long-standing steroids has to be given. DMARDs to stop or not to stop is a big question for joint surgeries. In fact, at Hinduja Hospital, we, at least with the 2 or 3 orthopedic surgeons, we are not stopping disease-modifying agents, but I am very aware that many orthopedic surgeons are very uncomfortable to do the surgery when the drugs are on. For them, I would probably say maximum of 2 weeks, a week before and a week after, because sometimes the patients are endlessly left without DMARDs after the surgery and they come with a flare on a wheelchair when they come to us. So if in case you're stopping, probably for a few weeks, not more than that. Biologics, when to stop and start, the guidelines have been very well given, and you can go and anybody can search the literature and get these guidelines, and we can use them. Orthopedic surgery in these long-standing rheumatoids for any joint area is done for only 2 reasons. One, severe pain limiting day-to-day activities. I would say 8 out of 10 things the patient is not able to do because of that particular joint pain. In spite of optimal medications of pain, which includes injections, nerve blocks, etc., yes, you would have to think of surgery. And second, there is no pain, but there is so much of a deformity in the joint that day-to-day activities are not possible. For example, if an elbow is fixed flexion deformity of 40 degrees and he's not able to, in the dominant hand, and he's not able to bring the arm to the mouth or comb his hair or do day-to-day activities, even though it's not painful, you would think of doing something for that elbow. These are the 2 main indications for surgery at any joint area, and they have to be satisfied. And the person who will say that the surgery is needed is the patient. It's not the rheumatologist, it's not the orthopedic surgeon, but the patient has to say that he needs it, and because they are the ones going through the difficulties. So damage to multiple joints, how do you approach it? This is very important in these patients, because this is not given usually in textbooks. This is from a few orthopedic surgeons that I spoke to that I've written down. Rule of the thumb for the upper limb is distal to proximal, hand to be made functional before elbow and shoulder. Lower limb, usually most symptomatic joint is often operated. If all joints are equally affected, hip first and then knee, because rehabilitation of knee will be a problem if there is a hip damage. Knee degeneration, more forgiving the hip. That's why they go for the knee first and then the hip. The hip first and then the knee. Hip surgery is a simple surgery than the knee. So for all these 3 reasons, the orthopedic surgeon says he would probably do the hip first and then the knee. At the end of the day, the surgery is very, very individualized, and the joint that is most painful is often taken care of. So these are some points that are important for us when we are planning surgery and sending them to the orthopedic surgeons. So a few important joint areas which are missed. Temporomandibular joint is an important problem which you are not taking care of. Prevalence is quite high. Usually in long-standing rheumatoids, pain is there during joint movement. Sometimes the pain is so bad that intake has gone down, mouth opening has gone down, and an MRI and scanning of that area can pick up a lot of abnormalities in the bone, the synovium, the disc, everything. So many things can be done apart from the usual conservative measures. You can give injection into the joint. You can give local steroid into the masseter muscle if there is a spasm. Botulinum has been used. Arthroscopy and arthrocentesis. I've been fortunate to have a very good facial-maxillary surgeon who deals with these TMJs, and I've been surprised the amount of benefit that can be given to these patients if referred at the right time. They remove they do arthroscopies into the joint and remove adhesions, and it can be done multiple times, and it gives a lot of benefit to the patients. And sometimes total TM joint replacement, which I have not seen any patient do thus far. Cervical spine is very important in these patients. The prevalence definitely has reduced because of our aggressive treatment, but still does occur in some of the long-standing patients. The neck pain is very typical with helmet distribution going up to the vertex It can be sometimes felt behind the eyes. Patients may have vertebrobasilar problems, including vertigo. So neurological deficit, atlantoaxial subluxations and changes on X-rays are common, but neurological deficits are to be searched for. And 10% die of unrecognized spinal cord or brainstem compression. But I would say be aware of any rheumatoid patients who have become suddenly immobile very fast over a few months, not because of joint damage or activity. If this is happening, please look at the neck, because that's sometimes missed. And these patients can have a catastrophic problem when they go for other joint surgeries. So these are the three types that are seen: atlantoaxial, subaxial, basilar. I mean, I'm not going into the details of this, just to say that MRI has helped us a lot with this, and there are a lot of criteria, a lot of lines that need to be drawn both on plain X-ray and on MRI to find out all these changes of the cervical spine. And the management really depends on whether there is a neuro deficit or not. If there is a neuro deficit, there is no waiting around. You need a neurosurgeon's opinion and a surgery for seeing what can be done as a surgical intervention. And if there is no neuro deficit, then you would probably go ahead and treat the pannus aggressively and see if the patient's pain improves, the neurology improves. And many times, many of these new drugs that we have are very useful in this. But the last point there that I'm making is very important. There is a move towards prophylactic surgery in very high-risk individuals. They have given a set of criteria for that, including angles and lines which are broken on imaging. And these patients may not have neurology, but may still be candidates for prophylactic fixations so that the neurology does not occur. Extra-articular problems are also important. I'm not going into the details. The two most important ones are rheumatoid vasculitis and amyloidosis. This also, the prevalence has gone down because we are treating the rheumatoids better, usually in late RA, which is what we are discussing. Typical vasculitic ulcers, hepatitis, serositis, and mononeuritis multiplex may all be important clinical presentation. There is a need for steroids, high-dose immunosuppression. Biologics have also been used in these conditions with some benefit. We've seen a few patients of secondary amyloid, and again, the prevalence of this has gone down because we are treating the inflammation better now, much better now with targets. And all of them had proteinuria. Creatinine was fortunately normal in all of them when we had seen them. DMARDs were continued. The steroids were initially increased and tapered. In two patients, because the disease was active in spite of many other things that they had taken, TNF therapy was added, and it did seem to help the amyloid too, apart from helping the inflammatory arthritis. So many drugs have been tried for this secondary amyloidosis, but nowadays we don't use much of these. The most important is the third point, which is there. Control of the disease and supportive therapy is the cornerstone. And if the disease is active and the patient has not used biologics, maybe a discussion and then usage of these drugs may not be a bad idea, because in some patients it seems to help the amyloid too by reducing the burden of inflammation. The bone involvement is very important, often forgotten in our patients. Osteomalacia is prevalent because the sunshine, ours being a tropical country, the tropical country is outside and we are often inside. We ourselves are inside and patients are more inside than us. So we have to be very, very careful about this. Osteoporosis is well known. RA itself is an independent risk factor because of the inflammatory changes and bone involvement. Reduced weight bearing is a very important thing in patients, especially with lower limb involvement. Drugs can be a problem. Corticosteroids, we all know, can worsen both the cancellous and the cortical bone. Many of our long-standing rheumatoid female patients are postmenopausal too, and many of them have had early menopause as well. So therefore, all these factors can worsen their bone, which we sometimes... So we need to have a high index of suspicion in these long-standing patients. Loss of height, kyphosis, are often the first thing. They may not give you the telltale sign of the first fracture of the wrist many times, but this is enough for you to at least ask for an X-ray of the thoracic spine and pick it up and do the needful. Because once there is a fracture, it's an established osteoporosis. Whether you do a DEXA or not is immaterial. You will need to treat them, making sure that there are no secondary causes. All drugs for osteoporosis can be used, but be wary of bisphosphonates because of the renal reserve and the GI problems that many of these long-standing patients in the 5th and 6th decade have. So we might have to switch over to the newer drugs that we have. I've sometimes found 6-monthly denosumab to be of good use in these patients, so that we can still take care of it. Cardiovascular disease is important. I'm not going into the details of it. So many of our patients do die of heart problems. We know the pathogenesis of the heart disease. Traditional risk factors, of course, they're at this age, but chronic inflammation, which is also there. Therefore, we need to take care of both these if we have to treat or prevent the coronary artery disease that can occur in these patients. This is very important. I'll just spend a few slides of time on this because they come with chronic pain. They've had this disease for a very long time. And treatment of chronic pain, we need to know, I've simplified this diagram because I understand this better, so I think it will help. Chronic pain leads to reduced movement. The reduced movement leads to weakness and stiffness of the areas. And when you try to move, it produces more pain. So this is one vicious cycle that's going on. The second vicious cycle is the chronic pain interferes with your quality of sleep. You might be sleeping for 7 hours, but you wake up feeling as if you've not slept well and you're not fresh. When that happens, it's very well known that it does increase chronic pain again because of sleep interference. You can see this in many people doing shift duties. The ones who do night duties for about 3-4 weeks have body pains. It's a very, very important factor. And over a period of time, if you have chronic pain, you have stiffness and weakness, you don't sleep well, mood disturbance does occur. And there are many other factors for mood disturbance in day-to-day life. So these three keep feeding each other: mood disturbance, altered quality of sleep, and pain. So this is a vicious thing that keeps going on. And we need to know how to take care of it. So we always give something for pain. We make them sleep better at night. And we ask them to do regular exercises. And we do talk to them about mood disturbance. And if needed, if it is very significant, a psychiatrist intervention may also be needed. So I've come to the last 2 slides. I feel patient education is the most important because they come with some ideas, some wrong, some correct, and we need to keep them online. The disease activity is still there, and it gives you a good feeling if you can at least pick that up and treat that well, because that's reversible, and at least that much part of the disability can be reversed. Articular problems due to damage, pain relief is important. Be wary of NSAIDs. Do not run away from steroids, short course or a short if needed. Damage to the joints, I've told you how to take care of them and how to do the pre-op evaluation. Atlantoaxial joints do creep up.
I think there is some internet issue. This was the last slide of Dr. Balki's presentation. There is some technical issues, and with this we conclude the talk, and now we start the panel discussion. Sir, excellent talk. I have few questions for you regarding the clinically suspect arthralgias or non-specific pain.
Yes, sorry, I lost the contact suddenly.
Yeah.
Was that your last slide only?
Yes, that was my last slide.
I think then
Okay.
nothing lost.
So we are starting.
Okay.
My question is to Dr. Ashok sir. Suppose a patient, young female, 25, 26 years old, she presents with widespread pain of 3 months duration with family history of rheumatoid arthritis. Her examination is perfectly normal. ESR and ESR 60, CRP 14, rheumatoid factor positive, anti-CCP negative. What will you tell? How will you treat this patient, sir?
Well, this is a patient who has some increased risk because of positive family history and has some symptoms which are not yet characterizable. So this is a non-specific kind of musculoskeletal problem. Now, this is typically the kind of situation where you have to decide whether disease-modifying anti-rheumatic drugs are required or not. If clinically there is no arthritis, you can go for imaging and all, and that may show some additional features. If that is the case, then also there are no clear guidelines as such at present that whether you should start treatment just based on this increased ESR, because ESR might be raised for some other reason also. But if you are convinced that there is no other reason for the high ESR and CRP, you may choose the intermediate path, that you may like to give something and keep the patient under observation. Do not start any full-fledged treatment, but you may offer some treatment and then carefully see whether it is making any difference to her. Because many times you will realize that the patient's complaints are actually those of fibromyalgia and rheumatoid is far, far away. And so don't end up in a trap that you have started something and then it continues and patient goes to somebody else and he also continues thinking that the previous person must have seen some physical signs. Must document clearly that there are no clinical features and this is just a trial basis, because we are still awaiting the results of properly conducted trials. And so in your own clinic, you may, for a short period, try to test whether treatment of any kind makes a difference. But you will feel convinced within a very short time that actually this is this way or that way. Okay. And if the ESR and CRP were also normal, I would not worry much about doing anything other than treating her for fibromyalgia drugs or symptomatic analgesics.
Sir, the second question is, suppose this patient, she presented initially with widespread pain and after 2-3 visits, she complains of polyarthralgias, inflammatory polyarthralgias with some amount of doubtful swelling of the few joints. Imaging is not conclusive and no other positive finding. Would you like to start any treatment at this particular time?
You see, it all depends on your own perception, because as I said, we have no set guidelines. We are still waiting to know what exactly is to be called imminent RA. So you have to, make a distinction between clinically suspect polyarthralgia and imminent RA. For imminent RA, a prediction model has not yet been produced. As I told you, you will be indulging in over-treatment with the currently available models. So in the clinic, whenever you feel inclined towards treating because you think the patient's symptomatology is very much suggestive of inflammatory process, you may start patient on anti-inflammatory drugs, you may start on disease-modifying drug on a trial basis. This will not be forever. You will have to see whether you are getting the desired results or not. If your treatment is leading to improvement, if treatment is leading to suppression of inflammation, only then. If there is no evidence of inflammation as such, then what will you monitor? So you will also have to have some parameters to go by. Purely subjective complaints, on that basis, it will be a complete experiment.
Absolutely, sir. Basically, we all see a lot of patients and we have follow-up of 5 years, 10 years, patient rheumatoid factor positive, ESR, CRP high, arthralgias, but even after 5 years, there is no development of arthritis, even
yes,
inflammatory arthritis.
That's true.
Yeah. Question for Balki. This is from Dr. Aman. Sir, experience with hand surgeries by orthopedic or plastic surgery?
Yeah. I was fortunate enough to work for a year. I know Dr. Ashok Kumar was also in Bath. He would know Professor Giddens. I used to sit with him for a year and look at the people, because he was a very good hand surgeon, and I learned all my tendon sheath injections from him. The first most important thing is that selection of the patient has to be appropriate, because otherwise, because patients with a lot of deformities in the hands have used all trick methods to get on with their lives, and they're doing things even today. So unless they really are, again, if pain is out of proportion or the deformity is interfering more than 80-90% of the times in their day-to-day life, a hand surgery is not required. So that's the first thing they do. The second thing is hand surgery can be of two types, a little earlier hand surgery and later. The earlier ones are, for example, attrition rupture of the extensor tendons of the hands can be leading to finger drops. This is a sort of a semi-emergency and has to be done early on, because otherwise the tendons get distracted too much and surgery cannot be done. So that has to be signed. The second thing, as far as hand surgery, one of the best surgeries to do for good hand function is a wrist fusion, because a grip of the hand, a lot of it depends on the stability of the wrist. And many times in patients with rheumatoid, the wrist is getting fused in an abnormal anatomy, either in ulnar deviation or there is flexion and they're getting, so the fingers are not working well, although they are not too bad, and they're dropping things because of the pain that they get from the wrist. So a wrist fusion is one of the good surgeries to do. And also sometimes small joint hand surgeries are done, but they are not as commonly done as these two things that I've spoken about. The tendon transplants are done sometimes in the hands, and replacement of the first carpo-metacarpal joint a few times are done for secondary OA. But otherwise, all MCP replacements are not something that is done very, very frequently by hand surgeons. They more often than not, if the hand is very badly damaged, go for what is called as, they do a fusion of the MCPs at an anatomically good place, so that at least the pinch grip and the power grip of the hand is maintained. So the hand is like this when you look at it after surgery. It doesn't extend like that, but the pinch and power grip is come. So these have to be really selected. So I would say that it's a much finer surgery than a TKR or THR.
Okay, Balki. Next question is again for you from Dr. Bharat. He's a rheumatologist at Jaipur. His question is RA and UIP type ILD. What is your take on management?
Right. Now, fibrosing ILDs overall there has been a big change over the past few years with the availability of pirfenidone and nintedanib. I think that we were using too much of immunosuppression in the past for these. So the first question we need to ask ourselves is it more of a fibrosing UIP, or is there something else apart from that additionally in the form of active lesions occurring now? If there is a patient with a fibrosing UIP who also has, let's say, a ground glass opacities, new shadows, and it's not infection or heart failure, which are the two things you have to rule out before you say it is a new shadow. And then in these cases, you may be justified in trying an immunosuppression steroid with another immunosuppressant, etc. But if it is just a fibrosing UIP without any evidence of activity there, then you're better off giving them nintedanib, because it is well known that in both IPF and non-IPF connective tissue disease related ILDs, UIPs, nintedanib given for a period of a year has improved or reduced the worsening of FVC in 1 year. So it's something that has to be, it does have its side effect, but it's something that we need to give.
Excellent. Ashok sir, I have a patient of undifferentiated inflammatory arthritis, like patient has right wrist and left ankle arthritis, markers negative, rheumatoid factor, NTCCP, HLA-B27 negative, X-ray normal. He had transient arthritis of 3 months. After that, he improved. So how long to treat this kind of patient? Seronegative, transient inflammatory arthritis.
Well, I mean, if in 3 months everything has become fine, wait for another 3 months and then you give a trial of withdrawal the treatment, maximum 6 months of treatment, and just observe. Because this might be just a single episode which may not occur again. This might be some disease which is going to come back. So and you need observation.
Yeah, because usually in viral arthropathies, we get polyarthritis or polyarthralgias, but sometimes we get this kind of transient synovitis also. Yeah. And Balki, a few lines about Felty's syndrome. What is your experience of Felty's syndrome in rheumatoid patients?
It's pretty rare. Maybe we are missing it, but we always look for it when the patient has it doesn't have to be very long-standing rheumatoid also. We've seen it in some people, which is also a few years, 4-5 years down the line. But we need to look at it in anyone who has a rheumatoid, a definite rheumatoid.
Yeah, Ashok sir, I have 3 patients of Feltis syndrome. They have rheumatoid of 10 years duration, then leukopenia. They on methotrexate and leflunomide, discontinued that, but leukopenia and that neutropenia part, splenomegaly, and then non-healing ulcer also. So they fulfilled the criteria of Feltis syndrome, and I tried everything, but they did not respond. So what is your suggestion? What kind of treatment we should start in this kind of situation?
It's a difficult situation actually.
Yeah.
Your treatment is treatment of rheumatoid only. This ulcer is going to respond if your disease responds.
Because sometimes it's very difficult to differentiate whether the cytopenia is drug-induced or because it is part of Feltis. When we get the complete triad, then we can make the diagnosis. But otherwise, it is difficult.
Very difficult.
And neutropenia is not common with drug-induced cytopenias. I think neutropenia is quite specific for Feltis syndrome.
Yes. So what you described is actually classical
Feltis syndrome. Yeah. There is a report of anti-TNF and rituximab also, but response rate is not very good, even with that.
Yeah. In a few patients, I've used steroids and they've helped. If they don't know contraindications and other things, they seem to help a little bit. But yes, we can't keep it. And many of our patients come down to a small dose of steroid and they continue, and that seems to take care of all aspects of the disease sometimes. Yes.
And Balki, what about the rheumatoid vasculopathy, like rheumatoid vasculitis? Sometimes patient present with mononeuritis multiplex. You even go for the biopsy and prove that this is rheumatoid vasculitis. How do you manage these kind of patients?
These have become rare, but the ones that I have managed, most of them have, we catch them early is the most important, because the problem with the nerve involvement is if it goes even for a few weeks, the recoverability goes down. Nerves don't regenerate at all, and they don't recover that fast. So I would say pulses of solumedrol and cyclophosphamide have been the fastest way of controlling the rheumatoid mononeuritis multiplex, at least. If there is no other, even scleritis, it helps. But when there is other features like hepatitis and all that, you have to be a little bit more careful. So the eye involvement, the serositis, the mononeuritis multiplex, these things do get better with steroids, cyclophosphamide, and TNF blockers have also been useful in these patients, some of them.
Yeah, particularly if patient has axonal neuropathy, then the recovery part is very, very slow and there is no recovery. Yeah, you're right. And what is your experience of biologics, particularly rituximab in rheumatoid mononeuritis multiplex?
I have not used much of that. Only one patient we have given. And again, probably it was given a little too late. The patient had taken other things and had not responded, and there was progression, and that's why we gave, but it did not help. You have more experience, Banwari. You must tell us.
If they come early, then even steroid itself is enough.
Correct.
In recovery.
Yeah. Correct.
And if they are late, you can do anything
else. Nothing else.
It won't.
But sir, would you like to treat early rheumatoid vasculitis with steroids alone or steroids with immunosuppression?
So what I'm saying is, I have seen patients recovering with steroid alone when they have come early, because steroid is the one which works fast.
Yeah.
If you give cyclophosphamide, its effect doesn't come before the third, pulse has been given. Or if you have given oral, cyclophosphamide, then also it will take its own sweet time. Steroid will work much faster. If something has to happen, it will happen quickly. And if it hasn't happened in 3 months, the nerve is probably gone.
Sir, Balki has discussed 4 patients of rheumatoid with secondary amyloidosis. And he treated with all kind of medication, all kind of combination therapy and biologics also. What is your experience about this rheumatoid with secondary amyloidosis?
Rheumatoid with secondary amyloidosis, in the past we used to, apart from controlling rheumatoid, sometimes we used to try cyclophosphamide and did succeed a few times, not every time. But later on, when anti-TNF came, anti-TNF definitely gave some dramatic results in many patients. So at present, I think our drug of choice is anti-TNF whenever we see amyloid. But if it is of long standing, we don't know. There is a lot of uncertainty whether something will happen. So in some patients, nothing happens.
Yeah. But even with anti-TNF drugs, once we achieve the low disease activity or remission in secondary amyloidosis, I think we have to continue this anti-TNF for long period.
Yes.
To maintain the remission part.
Well, I mean, it all depends on how much recovery takes place. Once near complete recovery has occurred and proteinuria, etc., has vanished, after that you may do away with anti-TNF because you would have controlled the disease anyway with something else in addition. So those are the cases who have been neglected earlier, not treated properly, suboptimally treated, and developed amyloid. Once you are effectively treated, then I think the condition stabilizes.
And the other thing is we don't have good imaging and markers for following up this condition. Serum amyloid associated protein is not something that is easily available. An amyloid scan, iodine scan, tagged iodine scan, is something that can give us you can at least repeat it in 6 months and see whether there's been an improvement in the uptake, which we don't have. So we go by the clinical features, we go by the inflammatory markers, the proteinuria. Then we do it.
Fortunately, the condition is now quite rare.
Yeah.
I don't.
But still we do see, sir. It is rare, but still we do see. And once patient develop these kind of complications, this is devastating. Yeah, you're right. Sir, what is your first line treatment in early rheumatoid arthritis? Like early young patient, 3 months, 4 months history, rheumatoid arthritis. What is your first line treatment now? Because now we have JAK inhibitors, we have so many biologics, and JAK inhibitors are very cheap.
I would still begin with methotrexate, hydroxychloroquine. I would still only start with methotrexate, hydroxychloroquine.
Yeah.
Unless there is some contraindication.
And methotrexate oral or injectable, sir?
Well, 85 or 90% of patients will be very happy with oral only. It's just about 10-15% who require parenteral, and I choose my patient who has to get the parenteral one. Because if I'm going to abandon methotrexate, then before that I will give a chance to parenteral.
And even after the 3 months of full dose of methotrexate and hydroxychloroquine, if patient has inadequate response, what will be your next choice?
Well, that's what I'm saying. If oral methotrexate has been given and response is not there, then injectable has to be given a chance before giving up methotrexate.
No, my question is even after 3 months of injectable.
Yeah. If that this thing is gone, then you see 2 drugs are already used. I may be able to give some time depending on the aggressiveness of the disease. If it is kind and can wait, I would add sulfasalazine also. Make it a triple therapy before subsequently going on to anti-TNF or other drugs. And these days the choice of JAK inhibitors is very much there. It is also affordable. So certainly in a young patient, that also is a very good alternative.
And some of the patients, they present with early aggressive disease. They have rheumatoid nodulosis. Although rheumatoid nodulosis is a late complication, but sometimes we do see an early disease also. And even after 6 months of adequate combination therapy, if they don't respond. So in that particular case, would you like to go with anti-TNF drugs or sulfasalazine? Aggressive disease?
Or what?
Or sulfasalazine, adding sulfasalazine as a triple drug?
Yeah, of course. Now, when you say rheumatoid nodulosis, you mean the lung nodules?
No. Subcutaneous nodules.
Subcutaneous nodules.
Yeah. Early.
Subcutaneous nodules may or may not be of great consequence. It depends. Yeah. Sometimes they are lying on the elbow and they don't bother anybody. So you don't worry about that.
so basically, even with that,
no. If it is accompanied by some other manifestations of aggression in the disease, then only you need to be that aggressive. But just seeing a subcutaneous nodule should not make you start worrying so much about the prognosis. There are so many patients who just have these nodules lying for years. They come and go.
Absolutely. My question was, even after 6 months of adequate therapy and that nodule, then even with that we can add sulfasalazine. Yeah.
If I find that the disease is definitely retaining its severity and needs more aggressive treatment based on the current assessment, then I will go for a biologic.
And sir, do you repeat this? Some of the patients we see rheumatoid factor repeated every time, every visit. The patient come with rheumatoid factor anti-CCP reports. Do you repeat?
No, not at all. I don't. I discourage that.
Yes, Balki.
Sorry, I just wanted to tell about an interesting patient, a lady with rheumatoid, seropositive rheumatoid, who developed nodules in the lung after methotrexate. The peripheral nodules were not much. And once the nodules came in the lung, as usual, all the tests were done to make sure that it's nothing else. And a biopsy also was done. And it confirmed Aschoff nodules in the lung. So all I did, and otherwise the rheumatoid was not very active. So all I did was I stopped the methotrexate, put her on a small short course of steroid and gave salazopyrin. The lung nodules have also disappeared. So I think this was something I thought I'd just put.
Yeah, very interesting. Because rheumatoid nodules and methotrexate nodules in lung cannot be differentiated without biopsy. And biopsy, we usually don't go for biopsy. Very rarely go for biopsy. Yeah. And Balki, what is your experience with JAK inhibitors now in rheumatoid arthritis?
Probably over the last, I would say, I follow what Dr. Joshi told me. Don't be the first to use it and don't be the last to use it. That is a nice advice that he had given me, and I follow that advice. So I didn't jump onto the bandwagon initially, but I have found, like rightly Dr. Ajay Kumar said, one very, very good thing about it is the cost is not much. So and it seems to work. So I have been using it in very resistant cases of especially spondylos, definitely. And it seems to give me that additional before I go on to the more expensive TNF and other things. And even in rheumatoids now I've started to use it. Somehow I've become a little wary about the combination of methotrexate and leflunomide because I've had at least 4 or 5 patients with cirrhosis. And that has, although people say it's a good thing, I've become a little bit more circumspect. I would rather use if the disease is very, very severe and the patient can't afford TNF, I would probably give methotrexate and tofacitinib if sulfasalazine does not help. So that's been my slow change. As clinicians, we are a little slow to make the changes that need to be done in the clinical practice. But this is a change that I'm doing over the last few months.
Sir, what is your observation about dyslipidemia part, thrombosis and herpes with JAK inhibitors?
Are you asking me?
Yeah.
Well, I have come across 2 instances of thrombosis, venous thrombosis, and hyperlipidemia also. I mean, something that needs to be monitored. I try to monitor in every single case because suddenly they come up with rising, LDL cholesterol, and that becomes a worry. Then, of course, I would like to say that tofacitinib is giving some kind of mixed results, very variable results. Somebody will have a dramatic remission. Somebody will come with, ESR is near 0, CRP has vanished, no clinical sign of synovitis, absolutely dramatic. And many more patients who will come with subjective relief, they will admit I'm much better. And then you look at the inflammatory parameters, they are where they were. And you examine the patient, there are quite a few joints which are, glaringly, swollen, tender, everything. But the patient seems to be very satisfied that, this is something which has worked. And then at that point in time, you have to really explain to the patient that actually not much progress has been made and we have to think of an alternative. So this is something very interesting about JAK inhibitor. When I first started using, my first few patients had dramatic responses and I got very impressed. And later on down the line, maybe 3 to 6 months later, my opinion was a little different. I said, no, this is also just another DMARD and anything can happen. Plus support the side effects. So now the excitement is gone, but we are happy that we have one more alternative. So that way our armamentarium is richer. You feel good about it because it's affordable also and non-parental. I mean, oral drug. So there are advantages.
And what about herpes, sir?
Herpes, I have seen rarely.
Okay.
Actually, I'm avoiding using it in elderly people.
Mm.
Trying to keep it, confined to the younger, lot. And with the recent FDA warning anyway, you would rather avoid it in people who are older.
Yeah.
If you have an alternative, then better avoid it.
But as Balki said, it is good in spondyloarthropathy also. It works in spondylo.
Yeah. We are using it. Also using in psoriatic.
So yeah, psoriatic arthritis also. So I think we had very good discussion on early rheumatoid arthritis, late rheumatoid arthritis. Both have delivered excellent talks. I think we can conclude the session with this. I thank Dr. Ashok Kumar sir and Dr. Balki and all the audience for the joining this virtual meeting on Sunday. So on behalf of Niramaya Arthritis and Immunology Foundation, I thank you all for joining this meeting. Thank you, sir.
Thanks.
Thank you.